Hello everyone, my name is Bucaloiu, and I'm an undergraduate research intern with the Geisinger Center for Pharmacy Innovation and Outcomes, presenting to you our research on the development of an evidence-based codebook for patient and clinician interviews aimed to understand communication about possible opioid use disorder, or OUD. Now, we know that communication between clinicians and patients at risk for OUD presents a significant challenge in avoiding negative and stigmatizing patient perceptions, which can be major barriers to effective interventions. In this study, we assessed known approaches to communicating OUD diagnosis and treatment to patients to create a qualitative codebook, which we will use to evaluate interviews with patients and clinicians that we're in the process of conducting. And now when I say codebook, I'm not talking about computers. I'm talking about qualitative coding in which we categorize and index text from interviews to facilitate our analysis. So basically, turning rich but messy qualitative data into more manageable quantitative data. Now, we performed a scoping review of Medline, 1946 to July 2021, to identify a communication framework around OUD to inform our structured qualitative approach. We selected qualitative studies describing patient-clinician communication and patient self-perception regarding opioid use. We also snowballed and searched reference lists for additional articles. We then abstracted and tabulated individual communication and self-perception themes from our search and added them to themes identified by our study team in preliminary patient-clinician interviews, to create this master codebook that will be used in qualitative analysis of our design phase interviews. So our team decided to use Henry 2016's chronic pain coding system, the CPCS, as the base of our structured codebook. Table 1 outlines its major categories. Now, while the CPCS's qualitative codes for clinician utterances are sufficient, the model lacks specific codes designed to capture patient terminology, self-perception, and communication tendencies. To address this, as you can see in Table 2, we added themes derived from preliminary interviews by our study team. We then added codes for patient discursive positioning, as outlined by Sibley 2020, to gain insight into patient self-presentation. We also applied a general code for any stigmatizing language that patients may identify, as well as code for positive and negative attribution that patients may make about certain clinician actions. Now, these qualitative codes will be applied to de-identified transcripts of patient and clinician interviews that we are currently in the process of conducting. So, few studies capture a comprehensive view into the subjective clinical experience of patients at risk of OUD. So we built upon existing models like the CPCS to draft a structured framework for our qualitative research. Going forward, data derived from this study will help us develop clinical communication training programs and inform the implementation of clinical decision support tools to help clinicians address OUD risk and optimize outcomes for the patient population. Thank you for your time and attention. Bye.